Good evening, respected professor and my dear students. I welcome you all for today's RAISA online DNB academics session. Today we have three topics: one 3 months old infant with Cleft palate management, and second one is sir, and by that will be presented by Dr. Muthupriya, and next will be a 6-year-old child with severe post-burn neck contracture, anesthetic management, and final will be diabetic infected foot for anesthetic management with almost metabolic complications. Without wasting much of time, I hand over the session to Professor and students. I invite Dr. Muthupriya to start the session with Professor's permission.
Yeah. So these three cases are very, very commonly given cases in the Viva short cases, and there are umpteen number of questions that can be asked, even though it is named as a short case. There are a lot of things to be asked in this particular topic. So we have to know many things.
Yes,
Being a short case, the questions will be different for different students because the same case will be given to almost all the UGs who are appearing for exams. So to avoid repetition, they may ask you different questions, and so let us see how to equip yourself to answer that questions from the examiners.
Okay, sir.
So you make a very short presentation. You don't have to go into the detail like a long case.
Okay, sir.
So your presentation should include what are all the important history you will elicit from the informer, because this being a 3-month-old baby,
Yes,
they
sir.
cannot directly give you any history. So you must get all the information that you need from the mother or the parent. So what important history you want to ask, and what are all the important clinical examinations you will do, and what are the challenges you face in anesthetizing this infant. These are the three important headings under which your presentation should be there. Okay? You can avoid all the routine presentations like a long case, patient looking well built, small built, anemic, and jaundice. Not all that can be completely omitted. Okay? So,
Yes,
make your presentation concise and relevant to these three headings. Okay, go ahead.
Good evening, everyone. My short case is regarding a cleft lip and palate. A 3-month-old female baby posted for repair of wide left-sided cleft of primary and secondary palate. So I'll ask the history. The informant is mother. They mostly present with complaints of nasal regurgitation while feeding difficulties, recurrent respiratory and ear infections. So we should look into the birth history and antenatal history, whether the child is a preterm or term baby, whether it's a normal vaginal delivery, birth weight, whether there is any history of ICU admission, whether there is any history of any congenital anomalies in the scan noted during the antenatal scan, and his mother intake of any drugs like anti-seizure medication, isotretinoin, alcohol, and developmental history. We should ask the developmental milestone for the child. Dietary history, we should look for in the nutrition, whether feeding history, whether the child is able to latch into the breast milk and sucking is adequate, whether there is a nicer regurgitation of breast milk, and what is the feeding being given, whether there is any history of Palade fields, etc. Immunization, whether the child is immunized till date, and family history, any similar defects in the family should be noted. Past history, whether there is any history of recent respiratory tract infection should be noted, and any past surgeries. Examination, head-to-toe examination, and vitals should be noted, and the room air saturation should be looked into. IV access should be noted. RB examination, we should look at the head-to-toe appearance, and usually we see a notching in the upper lip, and any facial deformities should be seen, like macrognathia, retrognathia, macrostosis should be noted. And on oral cavity examination, we can see a cleft over the left side, usually in the oral roof of the oral cavity. Investigations, routine investigations like blood grouping, cross matching, CBC, and echo if there is a murmur noted, and any congenital anomaly should be looked after. Chest X-ray, if there is a recent respiratory tract infection, should be noted, and ENT, pediatrician, dental, and cardiac opinion should be look if there is associated anomalies. And So my diagnosis is a left unilateral complete cleft lip and palate, posted for surgery. Since the child is a 3-month-old baby, we usually go for a cleft lip repair first. Following that, around 9 to 10 months, we go for palatal surgery repair. So my concern regarding this patient is it's a pediatric child of 3 months. That's anticipated difficult airway and shared airway with a surgeon. Prone for chronic respiratory infection, if untreated, can lead to post-op pulmonary complications, and there is associated congenital anomalies, and post-op airway obstruction should be post-operative airway obstructions are more common in these children. So after routine investigations, and we should give the NPO guidelines mainly for 6 hours for formula milk, 4 hours for breast milk, and 2 hours for clear liquids. We can pre-medicate the child with if there is no history of snoring and no difficult airway, we can pre-medicate the child with midas or ketamine or dexmed. Antibiotics should be given. The OT temperature should be kept around 20 to 24 degrees Celsius. All the drug doses should be calculated in advance and diluted appropriately. IV fluid should be given according to the holiday cigar formula, and monitoring, intraoperative monitoring, routine ASA monitoring, precordial step should be kept, and temperature monitoring. Then if the IV access is secure, we can go for IV induction or else inhalation induction with sevoflurane. Depending on the RV assessment, we should go for. And laryngoscopy, mask ventilation will be a bit difficult because of the cleft lip. There will be a leak of air, so difficult in intubation, difficult mask holding, and difficult extubation. Everything will be seen in this patient. And during laryngoscopy, since there is a wide left-sided cleft lip and cleft palate, the difficulty will be noted during laryngoscopy. Gauze can be kept under the cleft to prevent the trauma of the cleft over the cleft palate. And intubation will be mostly with a South Pole RAE tube. And the child is maintained with oxygen, air, and sevoflurane. Muscle relaxants like becuronium attract can be given, and intraoperative blood loss, fluid, and warmer should be kept. At the end of the procedure, after gentle laryngoscopy, we should look for any edema of the swelling of the tongue and uvula. Post-operatively, we should look for mainly for the post-operative pain relief, like with systemic opioids or infraorbital nerve block should be given. And after around 9 months of surgery, around 9 months, we should go for a cleft palate repair.
No, don't worry about it. It is only about the repair of the primary palate. No,
Okay.
3 months. Okay, so you don't have to go for the 9 months procedure where we repair the palate and all that now.
Okay,
Now
sir.
this thing, your presentation is over. So
Yes,
they
sir.
will definitely, even though I have worded it as the cleft of primary and secondary palate, at 3
Yes.
months we will do only the primary palate. That is the cleft lip only will be repaired.
Yes, sir.
Okay. Now a few questions I will start asking you. Why do you want the birth history? What is the importance of birth history?
Preterm neonates are more profound apnea of prematurities, and birth weight will be underweight.
Very good.
So
that is a very, very important history that you have to, especially infants which undergo surgery within the first 3 months after birth. If they up to 15 months after birth, 15 months after birth, if they undergo any surgery and if they are born premature and they have been treated in the neonatal intensive care unit, they are likely to go in for a complication called apnea of prematurity. What is this apnea of prematurity? What will happen in such cases?
During feeding itself, they would go for apnea, due to hunger, and there will be a loss of respiration for about 10 seconds, and after that
it happens usually only post-operatively. If any surgery is done, it happens only during post-op period of the surgery. It doesn't happen normally during feeding or during routine life. Okay. So the apnea of prematurity has an important clinical bearing only if a child undergoes a surgery within the first 15 months after birth, after being born as a premature at 34 or 35 weeks. If they are born beyond 36, it is not called prematurity. Okay, less than 36 weeks of birth, it is definitely called as a apnea of prematurity, I mean preterm birth, and they will have this problem where during the first 48 hours after birth, they are likely to go in for sudden apnea. It will last more than 20 seconds and result in desaturation up to less than 90% of oxygen saturation. Okay, and if not treated in time or recognized in time, there are instances where cardiac arrest also has happened because of the hypoxemia that ensued in those patients. Okay?
Okay.
So they require a continuous pulse oximetry monitoring during the first 48 hours post-operatively, so that any desaturation, you will get an alarm from the monitor and you can immediately attend to the child, give oxygen and stimulate the respiration. Just by tapping the child will start breathing. Okay, even though it goes into apnea, just any stimulus, either tapping the child or slightly pinching the child, will make the child breathe again, and we can immediately salvage. And this can happen 1 or 2 times in 24 hours period. So it requires a continuous monitoring with a pulse oximeter for the first 48 hours if there is a history of prematurity. Is there
Okay.
any drug treatment we can give to prevent this happening in the post-operative period?
Caffeine 20 mg per kg can be given.
They can be given caffeine, which is a stimulant of the respiratory center, that can be given at the dose of 20 mg per kg body weight as an IV preparation. It is available as an IV preparation that can be given just before induction of anesthesia, and that will make the child breathe in the post-operative period comfortably without this problem of prematurity. Right. Any other question you would like to ask apart from this premature birth? When the baby is born, nowadays a neonatologist or a pediatrician always attends on, even if it is a normal delivery. Now the present day concept is to ask for a pediatric opinion, or a pediatrician only receives the baby and assesses the baby's Apgar and other scores and gives his opinion. Okay, that has been the routine for any delivery, whether it is vaginal natural delivery or cesarean delivery. This has become a routine now. So
Yes.
is there any important history you should get from the mother regarding the baby at birth apart from prematurity? You mentioned some other congenital anomalies can be present, because
Yes,
this is one congenital anomaly.
yes, sir.
Other congenital anomalies are present. What is the most common congenital anomaly? You have to find out whether it was identified at the time of birth.
Like Down syndrome, trichotillomania.
Down syndrome. Okay, so syndromic children will obviously have those features. Okay, so
Okay.
patient will immediately be noticing it and telling it, but a thing which the mother cannot find out by appearance. What is the cardiovascular congenital anomaly that can accompany?
VSDs.
VSD, which is more common. VSD is more
VSDs.
common.
Yes,
So
sir.
only a neonatologist or a pediatrician will identify whether the child has a VSD or not, and immediately inform the parents that your child has a hole in the heart. This may close by itself, or we have to wait and see whether it requires any treatment. That information would have been given to the parents, especially in the present day context where litigations are very, very common. So the pediatrician would have given that information that child also has a congenital cardiac lesion. So these
Yes.
two important histories have to be elicited from the mother, whether the baby was born at full term or prematurely, and whether they got any information from the attending pediatrician that there is a congenital anomaly in the form of VSD or ASD present. Okay, these are the two important history about the birth you have to elicit from the parents.
Okay,
With
sir.
regard to feeding, you said, I will ask what is the problem in feeding repeated aspiration? What is the problem of asking for feeding difficulty? Why do you want to know about it?
Due to they won't be able to latch on the breast, sir. So that will
Okay.
be inadequate nutrition and malnutrition, failure to thrive in the baby, sir.
Very good.
And due to cleft palate also, there will be regurgitation, so recurrent infection to the chest and the ear will be there, sir.
Okay.
And so they are mostly palate, they won't be able to suck the milk, so palate feeds will be usually given.
Okay. Any other method of avoiding the nasal regurgitation to feed the baby?
Keeping the baby in sitting up position and
Keeping the baby less than 3 months, it is very difficult to keep the baby up and feed it, isn't it?
yes, sir.
Any prosthesis or something like that that can be given to fill up
Yes,
the
sir.
gap? And what is the name for that?
Operators, sir.
Operator. Very good.
Yes.
So plastic, they will take a mold of the palate, okay, and try to fix it up in that gap so that the gap will be closed. So during the time of feeding, the mother can insert that operator or the plastic shelf, it is called, into the oral cavity, which will get seated at the roof of the palate and cover that gap completely, and you can feed that. Is there any other indication for using that apart from feeding? If they have an operator and she says, I use that operator for feeding, will you give any instruction to the parent when the child comes for surgery? You can ask the parent to bring it and apply it as a protector. Instead of keeping your gauze roll at the gap to fill up that gap, you can use this operator to fill up that gap, and that will help you in preventing the laryngoscope blade getting caught in that white left-sided flap. Okay? So you can ask the parent to bring that. And this being a huge forehead body, it will not get aspirated, or even if it dislodged, nothing will happen. Okay? But it will definitely help you in laryngoscopy by placing this operator in position so that your laryngoscopy will be easy. Okay? So this is a very important information you should get well about the feeding. Right?
Okay.
Right. So all the other points that you have mentioned about the investigations and management, everything is okay. They will definitely ask something about the embryology of the defect, why it happens, what is the embryology behind the development of cleft lip and cleft palate.
Yes, sir. So primary palate and secondary palate you have. The primary palate is formed by the fusion of the medial nasal and lateral nasal and frontonasal process, forming the upper lip, and the secondary palate give rise to the palatal shells, which later fuses together to form the hard palate and soft palate, sir. So if
what time, what age of gestation they start forming, and what is the age by which it completes? The gestational age you should say.
Okay, sir. At around 4 weeks of gestation, 4 to 6 weeks of gestation, the primary palate forms, and around 12 weeks, 10 to 12 weeks, the secondary palate gets forms of intrauterine life.
Okay. So that is the time if they fail to fuse. See, now there is a central process, there are two lateral processes. Okay. So imagine there is a projection from the middle and two projections from the side. All the three have to get united. That is all the meaning of this projection of frontonasal process and lateral nasal maxillary process. All these things is nothing but three groups of tissues, one projecting in the center and two coming from the side. All the three have to get united in the midline. Okay, that is the formation of the primary palate or the lip. And secondary palate, if they don't come together to form the hard palate and shelves, then it becomes the cleft palate. So the primary palate is nothing but the cleft lip. The secondary palate is nothing but the cleft palate. That is the plastic surgeon terminology of calling the cleft lip and cleft palate. What are all the types of classifications of cleft lip and cleft palate?
WOW classification, VAU, WOW's classification, and
well, that is all mostly for plastic surgeons, but for our sake, for our diagnosis, what is the how will you, what is the you said it is a complete cleft of the palate on the left side. So this is a unilateral cleft. isn't
Yes,
it?
sir.
Unilateral
Yes, sir.
cleft of both the lip and palate or primary and secondary palate. What are all
Yes.
the other types that it can have?
We have the Indian Nagpur classification where the class 1 is cleft lip alone, class 1A is cleft lip and alveolar arch alone involvement, class 2 is cleft of the secondary palate alone, and class 2S is submucosal cleft, and class 3 is unilateral cleft lip and cleft palate.
So if it is a bilateral cleft lip, what is the challenge in that case?
We have a premaxillar protuberance, which is more prone for injuries during intubation.
So it may cause a challenging intubation. Okay, it may
Yes.
cause a difficulty in intubation. So any prominent premaxillary projection with a bilateral cleft of primary and secondary palate or lip and palate, it always has to be considered as an anticipated difficult airway. Okay, and which is the most difficult syndrome which is attached to the cleft palate, which is difficult to manage?
Peary-Robin syndrome.
Peary-Robin syndrome. Why Peary-Robin syndrome causes so much of difficulty in intubation?
So, Peary-Robin syndrome, that is a mandibular hypoplasia, sir. So the tongue won't be able to accommodate the oral cavity, and it will push the palate. So the palatal ridges can't fuse together and form a resulting cleft palate, sir.
Very good.
And they have a, due to mandibular hypoplasia, that will be difficult in mask ventilation also. Decrease in oral cavity size, so difficult intubation, everything difficult, sir.
Okay. So when you do laryngoscopy, what happens in a Peary-Robin child? Why you are not able to see the larynx?
Neonates, the larynx will be a bit anterior, and the tongue won't be able to push to the submandibular space of the oral cavity.
Very good. Excellent. So that is a very important reason. The submandibular space is not big enough to hold the soft tissue, both the tongue and the sublingual portions. Okay? So they will overflow and obscure your vision. Okay?
Yes.
However much you try to push it to one side, they will try to overflow and come and obscure your vision, and visualizing the larynx will be extremely difficult. So what are the methods of overcoming the challenge in a Peary-Robin syndrome? How to manage intubation in a Peary-Robin syndrome?
We can pull the tongue and give a tongue tie over it, or retropharyngeal, like coming on the right side of the palate, right side of the oral can do. Then,
any other procedure to make the mandible bigger and wait for the mandible to grow and then make enough space to do your laryngoscopy and intubate? Have you heard of mandibular distraction?
Yes, sir. Yes, sir.
Where you put pins on the outside and then try to pull it, gradually increase the length of the mandible. Okay, so you start as soon as the baby is born, before you attempt your palate repair. What type of palatal defect these Peary-Robin children have? Will they have a complete cleft or an incomplete cleft?
Incomplete, sir.
They usually have an incomplete cleft only. Okay. So in incomplete cleft, which portion of the palate is not fused? What are the parts of the palate?
Soft palate and hard palate.
Hard palate. So in the front you have the bony shelf, which is called the hard palate. Behind you have the muscular and mucosal part, which is called the soft palate. What are the muscles present in the soft palate?
Levator vale palatine, tensor vale palatine, palatoglossal, palatopharyngeal muscle.
So what is the importance of the soft palate? Why it is required for a normal growth and eating habits?
For like a speech nasal tone, to prevent
comes only after about 1 year when the child starts speaking. But before that, why there is difficulty in feeding or swallowing? What is the role of soft palate in our normal day-to-day swallowing activity?
To avoid nasal regurgitation, the soft palate closes the nasopharynx. So
how does it do? What happens exactly? The soft palate descends down and comes and touches the posterior pharyngeal wall. Okay? So the uvula should come and touch the posterior pharyngeal wall. It should come down like a curtain. Then
Okay.
only all the thing, whether fluid or solid, whatever we eat, will be rolled back over the back of the tongue towards the esophagus and not come above to the retropharyngeal nasal area. Okay.
Okay.
So during swallowing, soft palate has got a very important role of descending down and occluding the passage leading to the nasopharynx by touching the posterior pharyngeal wall. So when the surgeons do a palatal repair, if you see the good surgeon operating, you will see that palate would have been pushed so much that the uvula will be almost touching the posterior pharyngeal wall before you extubate. Okay.
Okay,
And
sir.
when the child is gagging at the end of the surgery, you will find the soft palate almost coming and touching the posterior pharyngeal wall. Okay. So that is what you have to require. And that is the important role for the soft palate in swallowing. Similarly, the airflow that happens once you start speaking is according to your voice. The soft palate only regulates the airflow through the nostrils so that
Okay.
your tone or your voice is controlled by that. When the soft palate is not able to descend, all the air will escape through the nostril. And that is why you get that nasal twang or nasal quality of speech in people who have not been operated properly for a palate repair. Okay. So what are all the surgeries that may require to alter the voice or get back a normal voice? What is the name of the surgery that is done to get a normal voice?
Pharyngoplasties.
Velopharyngeoplasty. Okay,
Okay, sir.
it is more. You have not only pharynx, you have to correct the soft palate also. So it is
Okay.
called the velopharyngeoplasty, where they will pull a part of the soft palate and stick it to the posterior pharyngeal wall. Okay, so that there will be less gap of air to flow through the nostrils. Okay, so that is what they do, and that is one of the surgeries that will be done. Right. So with this particular thing, I'll just go for my presentation. Sorry.
Okay, sir.